So if you look at the inhibitors now, the target is the bacterial ribosome again. So in bacteria, there is the 70S. The 70S, you have the 50S subunit and the 30S subunit. We already discussed 30S subunit. We'll go to the other target of our antibiotics, no? The 50S subunit. For mammals, you have the 80S, which is composed of the 60S and 40S subunit of the ribosome. However, if you look at this, there would be no interaction if we give our antibiotics at the usual dose, of the dose that we usually give in our patients. No? But in very, very, very high, hindi lang high, very high levels, these antibiotics that we have may interact with mammalian ribosomes. So we have the 50S binders, which are macrolides, very popular right now because I don't know, because during these COVID times, most of our patients self-medicate with azithromycin, pero we'll discuss about that later. And we have our clindamycin, very important, especially for anaerobic infections. Our chloramphenicol and streptogramins, and we already discussed this one, the 30S binders. And of course, you have to review mupirocin, no? You read your textbook later. Or, you have already encountered this one on how it acts. So this one is a topical agent, usually popular, the mupirocin, when we have wounds. No? Ang sikat na brand is Bactroban. So we'll go to the more popular protein synthesis inhibitors, which are the tetracyclines, macrolides, the glycopeptides, the chloramphenicals, and the clindamycins. So chloramphenicol before, siguro mga 20 years ago or more, no? 50 years, 30, 40 years ago, was very popular. So this came from cultures of Streptomyces venezuelae, and the crystalline chloramphenicol is neutral and a stable compound. It is soluble in alcohol, but poorly soluble in water. So if you have to give it IV, you have to the salt would be different. It is chloramphenicol succinate, which is used for parenteral administration. Again, if you look at all of our medications, may salt na siya. So here, chloramphenicol succinate, this is a highly water-soluble substance na dayon. Pero by itself, crystalline chloramphenicol is poorly soluble in water. So very important. Before entering the cell, the antibiotic enters the cell via energy dependent. And if you recall the previous topic we had, energy dependent man sila. Process and the exams, no, reversibly binds to 50S subunit in the 70S ribosome. No? So if the term by itself reversibly, hindi ano siya, bacteriostatic as a rule. But if you read the textbook, there are many exceptions. May mga exceptions pag ida, so you have to read your textbook reversibly. There are some antibiotics that act, no, as bactericidal to some bacteria. So this one prevents peptide bond formation. So if this is the 70S subunit, we have the 50S and 30S subunits. So sa 50S, yeah, so we have the donor site. Diraga so good, no? So the peptidyl tRNA at the donor site donates the growing peptide chain to the amino acid tRNA at the acceptor site in a reaction catalyzed again by peptidyl transferases. So after that, donor site kay pag-form niya, the amino acid goes to the acceptor site naman. So pag-donate niya sang amino acid, it becomes an uncharged tRNA. So eventually it goes out. The tRNA discharge of its peptide is released from the donor site to make way for translocation of a newly formed peptidyl tRNA. So the acceptor site is then free to be occupied by the next charge amino acyl tRNA and so forth. No? So ma-multiply na siya dayon to a peptide. So in short, chloramphenicol binds the binding of amino acid moiety of the charged tRNA molecule to the acceptor site of the ribosomal mRNA complex. The binding of the tRNA to its codon is not affected. Failure of amino acid group to associate properly with the acceptor site prevents transpeptidation reaction catalyzed by peptidyl transferases. So ang action niya is against this peptidyl transferase. So the peptide at the donor site on the ribosomal complex is not transferred to its amino acid acceptor and the protein synthesis stops. So ang action niya diri. So inhibit ang peptidyl transferase. No? So this is how it is in your textbook. The amino acid binding site are shown schematically. No? So review your textbook. It's the same. Pagka di, may acceptor and we have the charged tRNA. So again, chloramphenicol is a bacteriostatic broad-spectrum antibiotic. Broad-spectrum, pwede siya gram-positive, gram-negative. Before mga 20 years or more, it was used even for respiratory tract infection, may gram-negative and gram-positive infections. So it usually has aerobic, but partially anaerobic activity. So active against gram-positive and gram-negative organisms. It is active against Rickettsia, but not chlamydia. And most gram-positive bacteria are inhibited at concentrations of 1 to 10 micrograms per ml. And ang gram-negative bacteria are inhibited by concentrations of 0.2 to 5 micrograms per ml. Before, this was the best drug for typhoid, probably even today, because we're afraid of its adverse reaction. Haemophilus, Neisseria negentidis, and some strains of Bacteroides are highly susceptible. And for them, may mga exceptions, it might be bactericidal. Haemophilus, Neisseria. So as a rule, it's bacteriostatic, but there are some exceptions. Half-life is every 4 hours, but usually we give these medications every 6 hours. It is highly lipid soluble, low protein binding, and a low molecular weight. So it penetrates the blood-brain barrier even without penetration, without even inflammation. No? So miski wala go bug. Since most, or if not all, of our antibiotics penetrate the blood-brain barrier if there is inflammation. Pero here, like penicillin, high-dose penicillin, ceftriaxone, and the others can penetrate readily, including chloramphenicol. So it has good therapeutic levels in bones, pleura, acidic, and synovial fluid. So kanami gid antibiotic. Then the dose may not be lowered in patients with hepatic failure. May need to be lowered in patients with hepatic failure because it is metabolized primarily by the liver. So may hepatic problem, you have to adjust. And excreted in the inactive form by the kidneys. So toxicity, this was the main problem of chloramphenicol. Because in Caucasians, in Asians, kuno mas jutay, but eventually doon hindi na siya sikat because of the other drugs. Hematologic, no? There is aplastic anemia. Hematologic is aplastic anemia in Caucasians. And chloramphenicol, if you look at this, is given every 6 hours. So if you have a typhoid patient, outpatient, typhoid outpatient. No? Treatment, you might as well give your ciprofloxacin. Even cefixime can treat typhoid patients. No? So cefixime is given 2 times a day lang. Ciprofloxacin 2 times a day. Ceftriaxone in the hospital may be given once a day lang gani, no? Because even if, again, ceftriaxone, even if cephalosporins are time dependent, ceftriaxone can reach blood levels at high level, blood levels na taas, no? So it can be given once a day, ceftriaxone for typhoid, even for meningitis. No? So with that, nag-due tayo ng use ng chloramphenicol at the current setting. So for respiratory tract infections, chloramphenicol is good for gram-negative and gram-positive infections. But then with cephalosporins, with the other drugs that we have mentioned before, like quinolones and the drugs that we are about to mention, hindi siya given every 6 hours. Some will be given once a day, 2 times a day, or 3 times a day. So gadjutay na, because when we prescribe medications, it should be effective, safe, suitable. So suitability nagka-problema. Even though plastic anemia is rare in Asians, na-withdraw taman siya. Nagyutay pa. It's still legal to prescribe this one. Then again, gray baby syndrome. Remember these words, plastic anemia, gray baby syndrome in infants and pregnant women. So di pa siya mahatag. Then optic neuritis. As in all medications, hypersensitivity reaction. But not really as prominent as in your beta-lactam antibiotics. Pero sa diri ang common yung gray baby syndrome, hematologic, especially, tandaan yung term, plastic anemia, and optic neuritis. So, it prolongs half-life of phenytoin, cyclophosphamide, warfarin, tolbutamide, or propamide, and the others mentioned in your textbook. And hindi siya synergistic. If you give beta-lactam with your aminoglycoside, there is a synergistic effect. If you give beta-lactams, kaysang una, we used to give penicillin plus chloramphenicol. Gali kayo hindi pwede. So if you combine beta-lactams with chloramphenicol, it might antagonize the sidal effects of your beta-lactam antibiotics. So mas gahinay siya. So any questions? Wala questions? If you have any questions, ask Dion. So we'll go to the other drug. So sikat sa unang chloramphenicol, but presently medyo nadula. So you have the tetracyclines. Tetracycline by itself, talagsa na siya ginahatag. Before, it was used by dermatologists, even combining it with their topical agents. Pero kung kisara pa siya gyapon sa over-the-counter drugs, na mga oxytetracycline, no? As ointments, not as capsule. No? So tetracycline, una-una was discovered as aromycin, then eventually in 1950s we have oxytetracycline. We still use that as a topical agent. Then eventually in 1953 we have tetracycline. Talagsa na siya ginausar even by dermatologists because damo ko na resistant strain sa pimples. No? Then presently what we use is doxycycline. So doxycycline, nag-long acting na siya and more suitable siya. Kaya once a day na lang, minocycline, probably once or twice a day given. So, and ang iyang adverse reaction is less. So tetracycline is a short-acting one. Doxycycline, monocycline, minocycline are long-acting drugs. No? So as a rule, they are primarily bacteriostatic at therapeutic concentrations, and they are broad spectrum. So remember this, hambal ko lagina. Short-actings are your tetracycline, oxytetracycline, chlortetracycline. Tandaan yung ginaliwat-liwat ko, short-acting. Then you have the intermediate, but not used. No? Wala na niya. Demesclocycline and metacycline. What is available in the market is doxycycline and minocycline. But doxycycline, very cheap. Barato na siya. If you use the generic ones, wala pa nga ni pulo ka pieces. And it's given once a day pa. So again, it enters by passive division via porins and reversibly binds to the 30S ribosomal subunit and prevents addition of more amino acids to the growing peptide chain. So sa 30S siya ha. So it binds to the 30S ribosomal RNA at a site that directly binds binding of amino acid charged tRNA to the acceptor site of the ribosome mRNA. So tandaan nyo kung di sila action mga drugs ta. So in vitro activity, lipophilic congeners are more active like minocycline over doxycycline than hydrophobic ones. So in vitro. Absorption is primarily in the proximal small intestines. The concentrations, if you give tetracyclines, is after 1 to 3 hours. And most common, but again, miski ako ay kung nakaabot, tetracycline IV thrombophlebitis was very common. Chlorphenicol thrombophlebitis, again, very common also. So if you are in your third year, fourth year, sometimes you give the antibiotics. Some antibiotics you have to give very, very, very slowly. So kung is again na drip ka na sila. This one, it's not available ang IV in our country. Thrombophlebitis is very frequent. Nagadula na ng mga tetracyclines, doxycyclines, but we still use doxycycline really for atypical infections, especially respiratory, because of the advent of the other drugs that we mentioned sa mga cephalosporins and the other beta-lactam antibiotics. So we mentioned this already, ang aton short-acting and long-acting. So if you look at this, the short-acting, ang hambal sa umpisa, hepatic ang laban, metabolism. So if you look at this also, renal clearance of doxycycline, minocycline. So even if they have some sort of chronic kidney insufficiency, you can still have doxycycline and minocycline. You can still give it. So for tissue distributions, CSF levels are 10 to 26% of the serum levels, but we don't use that for meningitis, no? Gamay na siya. But here, if you look at this, tetracycline, but again osarta sumia doxycycline, it can be used for respiratory tract infection because if you look at this, ang maxillosinus mucosa levels approach serum levels. So, ga-penetrate sa maxilla and in the other respiratory tract system that we have. So, pwede siya matag sa respiratory tracts. All tetracyclines are concentrated in unobstructed bile. So, hindi pa siya pwede. Again, tandaan nyo niya ha. It all cross the placenta, accumulate in fetal bone and teeth. So, ga-discolor ng mga punto nila and it is excreted in breast milk. Sometimes, ang minocycline are given by our gynecologist for a non-gonococcal infection. So, basig na breastfeed or pregnant, be very careful. So, in renal and hepatic insufficiency, it should not be used in patients with renal failure except doxycycline because I mentioned this earlier. Tandaan niyo ha. Yes. Ang clearance ng doxycycline is low. Renal clearance is low. So, pwede siya. And probably also minocycline. Tetracyclines are slowly removed by hemodialysis but not peritoneal dialysis. Hepatic disease does not cause elevations. Toxicity, tandaan niyo toxicity, skin allergy, common. Pero ang mas grabe pagid ang teeth and bones, especially in infants. It's absorbed in the small intestine. Ang common pagid sa doxycycline are gastrointestinal symptoms. I can only talk of doxycycline in practice. Kasi we used to give that left and right also, especially in our gonococcal infections. So sometimes for gonococcal infections, we combine cefixime. We mentioned that earlier, no? Cefixime can be used for gonorrhea. And we add, because usually they say that if you have gonorrhea, you can also have the non-gonococcal urethritis of our patients. So we sometimes combine it with doxycycline. So it's given 2 capsules, first dose, loading dose, and 1 capsule once a day for 7 to 10 days. So ang problema sina, many of them would have GI symptoms, but be very careful sa pregnant, ha? So hepatotoxicity might happen. It's metabolized in the liver. It might aggravate pre-existing renal failure except doxycycline, pero be very careful magyapon. And you might have nervous and sensory system problems. So food adversely affects absorption, usually given on an empty stomach, but except for doxycycline and minocycline. So absorption is decreased by concomitant use of antacid, just like many of our antibiotics. Antibiotics to antacids like your aluminum, magnesium, or calcium, no, and ano pa iba yan? Sodium, no. Antacids, it might decrease absorption. So sulfate, milk, iron, multivitamins, and of course you don't use cimetidine anymore. So it might be decreased. So wala siya ginadungan diri. It might potentiate effects of oral anticoagulants. So pwede man. It might have antagonism. So if you combine, no, this with, ang ginagina example ko, NGU, gonococcal infection, gonorrhea, and non-gonococcal urethritis. If combine cefixime, which is a usual practice, plus doxycycline, the side effects, there might be antagonism in vitro. In vitro. That's why when you practice later on, you should all miski memorize mong textbook. You have to read the guidelines. Kung anong common na mga, for example, if you're treating sexually transmitted disease, anong common mga resistant patterns in the community. So in vitro, not in vivo, they might have antagonism. Pero, in-emphasize siya because we should be very, very careful. So any questions? Wala question. Remember the mechanism of action kung 30S, 50S. Ano pag indications, no? And common adverse drug reactions. So we'll go to the more popular case, megaresita macrolides. No? So before we used to give a macrolide available was erythromycin. No? This is the structure, no? And they changed the macrolide there. So it is derived from a strain of Streptomyces erytheus. Nagla mo siyang halin sa Iloilo fungus. It is poorly soluble in water. Again, ang pure erythromycin, hindi mo pwede imnon. It is rapidly inactivated by gastric acid. Susting ang may capsule kita sinikag syrup. And inconstantly absorbed after oral administration. So pure erythromycin, doon hindi mo pwede mahatag orally, just like your penicillin G. So action, again, reversibly binds to the 50S ribosomal subunit. So blockage of transpeptidation and translocation. So same action na, macrolides, clindamycin, streptogramins. So mechanism of resistance. Take note sa mga mechanism of resistance. Of course, you should know the mechanism of action. Kita nandito may resistance ang antibiotics ta. So reduce permeability of the cell or active efflux. Production of esterases that mean hydrolysis macrolides. So gumawa niya macrolides. Modification of ribosomal binding site by chromosomal mutation or by macrolide inducible or constitutive methylase. So dito man siya sa binding site. So if you take in your macrolides, ang classic na erythromycin, it's distributed through total body water and it has high concentrations in your alveolar macrophages and your PMNs, no? Mga neutrophils ta. Pero it poorly penetrates your synovial fluid and is transferred across the placenta. It is erythromycin is excreted in breast milk, concentrated by liver, and excreted into the bile. The erythromycin has a short half-life. So usually, we give it every 6 hours. So appreciable serum levels are maintained for 6 hours. So 4 times a day siya ginatag. That's why siguro one of the reasons why this is not popular because of this one. Permi mo siya ihatag, kalaway pala sa sabon. Because before, we used to give erythromycin, kaya wala pa to sa una mga kinolons, if you're allergic to sa mga penicillins. So kung may respiratory tract infection, allergy sa penicillin, hindi pwede amoxicillin. So we gave erythromycin. If you look at this, erythromycin by itself, no, hambalta, no penji siya. Maguba siya sa tiyan, di ma-absorb, damo problema. So cannot be given orally. So here, anong ginhimo nila? Ang ilang salt. So if you give erythromycin stearate, you can give it orally na. Ethyl succinate and estolate. So ang salt nila, ang apelido nila, ang ginalain. So lactobionate and luceptate is given IV. Siyempre immediate ang if you give give it IV, serum concentration nagtaas dayon. So if you change, no? If you change the salt, the action is different. Pwede na siya ihatag orally. They survive the gastric pH, no? So peak serum levels, lain man. It depends on the salt. So ang tawag sila sa generic name niya, erythromycin stearate or erythromycin succinate or erythromycin estolate. So I have no experience with the IV, pero before we used to emphasize this one. Or sa una, wala pa sa generics law, we write the erythromycin and the brand name immediately. So tandaan nyo, the salt makes a difference, especially in erythromycin. So adverse reaction. So irritative reactions, thrombophlebitis, allergic reactions. Again, cholestatic hepatitis in estolate, no? Oral form ang estolate. Transient hearing loss, and again the arrhythmia, torsadepon, the arrhythmia that we had. If you give it IV together with your base sa una to ginadungan pag nila sa terfenadine and astemizole and subong kay why na sila. If you give it with your antifungal medications, you might have the arrhythmia. So be very careful. But again, wala naman siya sa atong market. And pseudomembranous colitis was more common when we gave erythromycin before. So drug interactions, incompatibility with IV preparations of vitamin C, B complex, tetracycline, chlorphenicol, heparin. But you don't give it anymore, because of the advent of the cephalosporins, which are more stable and mas damo siya maigo nga bacteria and more specific and less adverse reaction if given IV. So it forms inactive complexes in the cytochrome P450 enzymes. So amo na bawal siya with other drugs, and it increases bioavailability of digoxin. So if you're giving your lanoxin or digoxin, be very careful. Plus the other drugs, if you give your digoxin na, tandaan nyo later on when you go to practice, check always. Fortunately right now, may internet na sa cellphone ta. So usually when we prescribe it, hindi ko na ma-memorize if you give digoxin, but again, gina-check sa websites nila. So erythromycin, the classic drug, short-acting siya, and presently not very popular because of the advent of clarithromycin and azithromycin. So clarithromycin and azithromycin, ala na dula na siya. So mechanism of action and resistance, the same as in erythromycin. Azithromycin has a greater activity against gram-negative bacteria. Gram-positive bacteria, habal na clarithromycin more than erythromycin and azithromycin. And clarithromycin is also a second-line agent in mycobacterium infections. Pero, I don't know if Many of you already nakaagi ng COVID, or if your relatives had COVID. Pero may question lang ko. Bayatan, question lang. Ma-question lang ko, hindi siya academic.
Good morning, Doc.
Morning, makata ko. Na may kilala ka na COVID? Present.
Yes, Doc. Sa family ko.
Ay, sige, very good. May ma-good na, hindi ba? Very good. Na, anong ginatag sa ilang abulo? Question lang. May idea ka?
So, totoo lang, Doc, hindi ko kasampot sa sa viral.
Admitted? Admitted, remdesivir?
Admitted. Yes, amo na siya, Doc.
Sige. So, ano pag yun? Wala na?
Ginagaan lang si mama ko sa anti-coagulant.
Si mama mo, Gid?
Oo, Doc.
Ay, oo, Clexin, no? Clexin. Ano pag yun? Wala na?
So far, mala na siya, Doc.
Wala siya nag antibiotic?
Hindi na ko kadumdum na gid, Doc. But do amo to sa ang ginhatag gid kay mama kay do nagalagit sa. Oo.
Do sang mga last year na, no? Kay subong
last year lang, no?
Kay do subong do hindi na grabe at ang COVID for vaccinated individuals. Sige, thank you, Vida.
Thank you, Doc.
So, isa na lang. You still have to read your textbook. So, kailangan matapos ko by 9. Araneta, present. Araneta, present.
Morning, Doc. Present.
Morning. May kilala ka na COVID? Wala. Why?
May ara, Doc.
Sige. Anong natag nga bulong sa iya? Or manasuspect na COVID?
Nang sa pag-remember ko, Doc, do acyclovir, to ba, Doc, mo?
Wala acyclovir, ha? Acyclovir is given. Anyway, why hindi nyo pa man na lesson? Acyclovir, remdesivir ang ginatag. Acyclovir is given for mga chickenpox na yan or ano pag yan
Ay, okay. Hindi lang ko sure, di lang ko sa doon.
Wala kang antibiotic na dumduman.
Wala, Doc.
Sige. Sige, thank you. So anyway, some of our patients who have atypical infections, no, atypical. Kung isa mga COVID patients na nagsuspect sila sa may secondary bacterial infection, they usually sometimes give azithromycin plus your third generation and second generation cephalosporins. Usually third generation. Kung secondary bacterial infection. So azithromycin ang popular subong because it has gram-negative and atypical sa typical infections like Legionella and the like. We will discuss that in internal medicine. So, partner lang azithromycin na nagsikat. So, there was a time, hindi nga year lang ho, nagdamo ang mga pasyente, nagsige bakal even though if it's illegal, no? May antibiotics, may kilala sa butika, nagbinakal azithromycin. So, I think mga 3-4 days wala azithromycin sa butika. So, clarithromycin. Sorry. Sige ako. May question?
Doc, excuse me, ma-ask ko tani, Doc. Kay, before, may kilala ko nga na COVID plus ang parents ko man before. Nabatian, nila, Doc, mo man nga like, kung ma-COVID ka, inom ka na daan, azithromycin for 5 days, kung like, grabing ubo, mo man na.
Correct, hindi. Hindi, kaya medicine. Hoy, wala man yung correct na to na may gani kaya gamakot. So matchag mo correct na hindi?
I think hindi, no.
Yes, hindi think hindi gid except if you suspect secondary infection.
Okay, inform ko na sila, Doc, kay duway man kina sila gapamati.
Paano sila kabakal? Usually ginagaan sa iba na physician, like if I get ambi kung may na-refer, kaya usus mo online kung outpatient. So, hindi ma-examine sang doktor, hindi man ka-auscultate. So, kung case, ambal ka gani, basi sala, basin tsakto, ginadugangan lang yung azithromycin. So, thank you. Wala ko na notice. So, anyway, ginagaan na azithromycin kay if you look at the spectrum activity, may gram positive, gram negative. Pero, it's for the atypical infections that are common if you have viral infections. No? Hindi gani common na sometimes ara. So halos tanan sila may azithromycin even for admitted patients. So amo na siya ang ginahimo na concoction sa most of the patients mucolytic. Tapos na mucolytic ang ilagay na piri permi acetylcysteine, pero kung ako, okay man lang na. So, ano pa gilang ginatag lang isa. Then, antihistamine, kaya katol ko, no? So, some would give cetirizine, some levocetirizine. And this one, like mentioned by your classmate, though hindi magsanto nga matag azithromycin. But again, some physicians give it. So, ang iba niya, mga sige lang, hala, nagubo-ubo, nagsige azithromycin. Ang problem ta, resistant strains na sa ulihi. Basi sa ulihi, just like what happened to amoxicillin, before, we used to give amoxicillin left and right, pati tiyanggi, nagbaligya na. Hala, halos tanan niya kagaw, tapos hindi na pwede amoxicillin. Same with cotrimoxazole, kaya nag-left and right mo na siya. So, ang kinakulbaan ta subong, if all of our patients, siyempre damo na taga-COVID subong, but not admitted, masigin na lang bakal azithromycin. So, mention ko lang na siya kay pasikat-sikat. If they go to our clinic, sila naka-azithromycin na sila, sige, pag-yapon ubo. So, careful lang if you give, no? So, if you give medications, especially antibiotics, think of resistance na. That's why you have to read on mechanism of resistance pag sa mga bacteria in your exams. No? So, halos ang clarithromycin, di halos parehas man. 50% bioavailable, metabolized in the liver, 65 to 70% of the drug is protein bound in the serum and excreted in the urine. So, clarithromycin, butang ko na lang di ang azithromycin penetrates well into the phagocytic cells. No? So, pagkaon sa phagocytic cells, especially sa respiratory tract, it stays in that area for long periods of time. Dugay siya. No? Take note of that. So, pagkuha mo sa blood level, sala nadula na siya. Pero, ang action niya sige pa because ara siya sa macrophages, kag mga phagocytic cells in the area, like your respiratory tract. So, it poorly penetrates the CSF, so sa mga meningitis without action, excreted in the urine. For clarithromycin, look out the half-life, medyo lawig, 5 to 7 hours. We'll go to azithromycin. So, clarithromycin, usually the usual clarithromycin is given 2 times a day. For adults, it's 250 to 500, 2 times a day, usually 7 days. Ano pag yun? Ang problem nila usually sini GI problems. And sometimes combined with your macrolides. Hindi, macrolides, with your beta-lactam antibiotics. So for pneumonias, with some mixed infection, they combine clarithromycin or azithromycin plus a second or third generation cephalosporin because it will cover, again, if you recall, ang third generation cephalosporin laban sa gram-negative. Tapos, ina-combine ka sa macrolide. If you combine it with the macrolide, may action na siya sa typical infections plus gram-positive coverage. Kaya namin siya sa gram-positive, no? So, gina-combine siya kung kisa and standalone man. Kaya may action na siya sa gram-negative pero not as strong. So, azithromycin, food decreases absorption by 50%. The best timing for azithromycin is to give it on an empty stomach. So most of our antibiotics, the rate of absorption is affected by our antacids. So protein binding in serum varies between 7 to 50%. So mas nami ni nga gutom. If you read your textbook, kagsang una, we had an azithromycin. Azithromycin may be given, ang usual dose 500 milligrams for 3 to 5 days. For some infections, galambot 7 days. Pero usually sa respiratory tract infections, common, it's given 3 to 5 days. Best timing, wala unod ang tiyan. And before, nagpagwa sila azithromycin that is given only once. Kisa mo ng imnon, ang timing sila sa tunga sang gabi nga wala unod ang tiyan. So ginasure mo wala unod kaya parang absorption dako. So this was not very popular but still available in some countries. I think mentioned in your textbook. Because of the GI problem. So again, look at the half-life. It's 2 to 4 days in the area that it concentrates. Sa respiratory tract. So high concentrations in sputum and lungs. Half-life long dito sa area nga gatinir siya. Pero sa blood, basi madula na siya dayon. So lain ang serum half-life ya, lain mga half-life ya sa macrophages. Routes of elimination, biliary and transintestinal. Adverse drug reactions, azithromycin does not form inactive complexes with cytochrome P450. Clarithromycin may decrease serum concentrations of zidovudine, and clarithromycin may lead to digoxin toxicity. So careful. Ang mga dumasikat ang azithromycin over clarithromycin. Although I mentioned gali, clarithromycin, the usual clarithromycin is given 2 times a day, but they have this OD dose. So ginahatag mo na siya once a day na dayon in special preparations, no? Kaya sustained release na siya. So the other drug na wala nagsikat, nag-take off sa Philippines was the erythromycin. So and roxithromycin. So before may roxithromycin and erythromycin in our country, pero I think roxithromycin is still available as a generic drug. Pero it has less active, roxithromycin has similar or less in vitro activity to erythromycin and less activity to erythromycin against Legionella. Because of the advent of clarithromycin and azithromycin, halos nadula ng roxithromycin and erythromycin. Okay? It's also given 2 times a day, except in some sustained release drugs. Tapos ang action niya not as strong as clarithro and azithromycin. So nadula na sila matamat. So any questions? So macrolides very popular, usually sa respiratory tract infection. It might also be given for gynecologic infections. We'll go to lincomycin and clindamycin. So again, action ha. Reversibly binds to 50S ribosomal subunits, shows blockage of transpeptidation and translocation reactions. Tapos tandaan yung clindamycin nga, if you go to an ENT physician, no? Or miski guro sa dentist, pero talaga sa dentist, kung may infection, tonsillitis, kung isagatag sila dahil clindamycin as opposed to the macrolides, no? Gram positive. Because ang reason sina, because this drug may gram positive action siya, slowly bactericidal against staph aureus, and same activity as staph in erythromycin. So do macrolide man siya, but it has significant action against anaerobic infection. So imbis magatag ka 4th generation cephalosporin or the other drugs that we discussed before in sa beta-lactam antibiotics that have action in anaerobic infections, more economical ang clindamycin and more practical. So it's pwede siya oral, no? IV oral. So usually amo na staph, gram positive, plus anaerobes, we give clindamycin. So mechanism of resistance, the same, alteration of a single 50S ribosomal protein at the receptor site, alteration in the 23S ribosomal RNA of the 50S ribosomal subunit, and active efflux of the drug. So gagwa ang bulong dayon pagsulod niya. Absorption is 90% and is slightly delayed but not decreased by ingestion of food. So nami pagid siya, if you start it IV, no, sa hospital, hindi ka kaon. Pagpuli iya, because if you have anaerobic infections, you might give the antibiotics for long periods of time. Pwede siya oral, no? But it's not given in anaerobic infection, especially in the CSF. And it has high concentrations in the bone and abscesses. So nami sa mga no? PMNs and macrophages. So ang advantage sa anti-staph like your clavulanic and amoxicillin, clavulanic plus amoxicillin, it has anaerobic activity. The half-life problem is you give your clindamycin every 6 hours. Kung 3 times a day mo siya, sometimes hindi siya as effective. But the half-life is 2 to 4 hours, metabolized in the liver and passes the placental barrier. So kung pregnant, careful na naman. Take note of the adverse reaction again. Allergic reactions, diarrhea, GI man yung problem, no? Hepatotoxicity, hematologic abnormalities. Kailang lecture ko nila isang Christmas. Any questions? Question?
Doc.
Sige. Okay.
Ang doc, may nabi like do role bala doc like for pimples nga like SOS, clindamycin bala doc. Like like usually kung damo pimple, sige lang po ang doc. Like is it okay doc nga like kung parang like sa isabi ka bulan doc ginagamit-gamit man siya per like to ka intermittent lang bi nga use doc?
I do not know. Makot sa derma. Pero in theory, hindi ko intermittent mo yan. Ikinampat yun mo gita na. Hindi ko kasabata because topical na siya ba si dermatologist ang kinanlan mo. Pero, in theory, you have to kill all of the bacteria. Nga arada, hindi ba? So, I don't know the duration. Kailan mo ng topical. Pero nga mo na siya ginausarta kay basi ini sa staff or use. Mas damo siya sa gram-positive. Anaerobic. So as needed use, kung ako mangkuton, basi hindi pwede, no? Pero the skin, ang problem sa skin kay kumang na most of our topical agents cannot penetrate it. Pero kung open na siya, some of our antibiotics, even our aminoglycoside, nga ano ganina, nga bacteriostatic, ganyan, balta ganyan, bacteriostatic yung action, no? Becomes bactericidal. Kay topical siya, may direct contact sila dayon sa drug. So maybe ang topical agents are given at a shorter period of time if it gets into contact with the bacteria. Pero ang imo pamangkot dito hindi ko sabat. Pero ako ang rule kinahanglan, if you have to give your antibiotics, you kill off all of the bacteria that are there present. Amo na siya ha. Hindi ko sabat.
Thank you.
Pwede ko ka-add sa kay Melissa.
Sige.
Ang sa derma bala, I don't know if correct ang ihambal, pero ang instruction is after a month of using erythromycin, it-change daw sa clindamycin. And then after a month, change naman daw sa erythromycin.
So every day nyo ginausar. Every day na siya ginausar.
Every day for a month, then change daw sa clindamycin, and after a month sa clinda, i-change naman to erythro.
Ang mamakot si mo nga gina-change.
I think, Doc, because of persistence.
Yes, so okay pa kaya basi mag-develop resistance pathogen mo siya. So ang rules ang imo ng doktor is to kill all of the bacteria. Gali kay gaya attract ka permi bacteria, that's why you have to give it always. Pero kinahanglan mag-usar ta antibiotics, you have to kill all tanan gid ya pathogen mo ha. Gali kay basi budlay gid na pathogen kay gatubo sila permi. So ga-culture ang aton pimple sa bacteria. So maybe amo ng reason. Hindi kayo magambal diretso gid. Pero amo na siyang reason i-change mo kay kung same lang siya antibiotic for long periods of time, will develop resistance. So ang kagaw mo hindi na ma-work. Ano clindamycin and ano ganito?
Erythromycin.
Erythromycin, clindamycin. So I cannot comment. Yan. Pero amo na gurang reason. Ang kinahanglan ta mabalaan kung why. If they are given, like why they are given. Kay kung kung yatag mo lang ang 1 week lang, it will develop resistance strains. Pero ang exact answer, maybe I have to read more on that. Sige. Any other questions? So if there are no questions, please read your textbook naman ha. And read your textbook and you'll have a quiz at I think 9:45. 5 items lang, but kailangan mabasa ka mo permi. So may mga exception and there are other drugs, you read on the other drugs. So wala question. If you have no questions, thank you.
Excuse me, Doc.
Mera, sige.
Regarding the what's COVID, Doc, kay akong cousin, so recently, COVID siya, and ang gin-recommend sa iyas ang first yung doctor is azithromycin. Dayon nagpa-second opinion sa lain nga doctor, nagambal siya nga hindi recommended ang azithromycin pero nag-recommend siya sa ferroxim. loratadine, flumicil, colchicine, prednisone, doxycycline, doc. Amo ni reseta daw
Ay, hindi ko kabalo.
lubalabakid.
Nga naghapo, nagasma, naghapo, na ginaguro eh.
Ang cefuroxime ko na doc paragid sa COVID. Amo na ang
Pero hindi
ginambal sa kasi.
pwede. Dahil lang, number one, anong COVID? Basi way ka mo nag-insindihan na eh. Anong COVID?
Virus, doc. Amo na tingala
Ingatan
ko
mo
doc
tayo
kay
ba yun?
daw
Anyway,
cephalosporin na doc.
why guro sila nag-insindihan na eh. Pero mas popular ang azithromycin, but in admitted patients, since we also handle admitted patients, pero ginapa-manage ko sa iba, you might have secondary community-acquired pneumonia. So, ang ginahatag sometimes are third-generation cephalosporins, your pipertazo, sa mga may secondary infection, di ba immunocompromised sa mga secondary infection, and more often than not combined with azithromycin for the atypical infections. So, amo na siya ginatag. As for your mucolytics, ang sikat subong acetylcysteine because they say it has also antioxidant property. For doxycycline, hindi ko pabalo. Usually, we reserve doxycycline for COPD patients. Kaya ginauna ta mga inhalation. So, for admitted patients, bawal ang nebulize in some areas. So, we use the inhaled. Many physicians would use albuterol plus ipratropium. Kaya may bronchodilator effect. Doxycycline siguro gina-reserve ta sa mga hindi pwede ka inhalation or spray or ano na to sila? COPD patients. Sige. Anyway, tapos na kamo sa asthma topic. Kaya sa many of our patients, if you look at the mucus of the COVID patients, perti ka sticky. So, permiara si acetylcysteine. Ano pag sa mga iba niya bulong? Cefuroxime, azithromycin.
Doc. Clopidogrel kag colchicine, doc.
Clopidogrel? Clopidogrel, I do not know, but in the guidelines, they are giving enoxaparin. Na? Enoxaparin niya may studies. Give Clopidogrel. Hindi ko balo, pero short of, basahin na lang, guidelines. You can read that on the guidelines. May guidelines ang, because basi may nakita ng iba niyang doktor. May iba niya problem ang ila physician. So, clopidogrel, antiplatelet is different from the action of our enoxaparins or of our heparins because in the studies, heparins ang inausar. So, lain man ila action ha. I will be discussing the action of heparins with HEMA. Basi si Dr. Joyan De Castro. So, lain ang action nila ha. Because in theory, we give, in theory, hindi. For our patients, no, with COVID, damo may storm nga katabo. So, tanan niya cytokines involved. So, that's why they give steroids. The steroids that is recommended is dexamethasone. Anyway, we'll be discussing dexamethasone. Kay long-acting siya. And mas due tayo nga dose kinahanglan mo. So, usually, amo na ginahatag in the guidelines. Pero, siyempre, ang physician, mayroon siguro nakita niya iban. And maybe, wala ka mo nag-intindihan sa inyong physician. Asang imo kasing. Kiti, hearsay man lang guro iya ginhambal. Pero may mga guidelines these are accessible, no? Ang National Institutes of Health mayara our Infectious Disease Society mayara man sila gina-publish, no? Ang society namon sa allergo mayara man gina-publish sa mechanism of action of the drugs lang. Pero ang guidelines are with the PSMID. Kung curious ka after your exams, PSMID, PSMID guidelines. So they renewed the guidelines, I think 6 months ago. Sige. Pero nami gina if you have relatives nga may miski kamuda nga may ginagaan bunong read on it. Kay miski ginahambal ko di nga mapati ka dayon basi sala na iya. That's why hindi ko mag-comment sa their mga treatment because ang nabalaan ko basi 2 decades ago pa and I'm not updated. So any questions again? So if there are no questions, basa na kamuliwat ha. Most of the items will be from this topic. And 1 or 2 from the other topics. 5 items na. So thank you. For the may correction ganito tanan ka mo hindi man na +1. Hindi +1 para ang the question that you mentioned before part is nalipat na ko. So if you have questions, i-post nyo lang. Kung personal, i-text nyo. Kasi hindi ko mabasa ang ako nga messenger group. Messenger nga personal, no? So, if there are no questions, we might have a quiz again tomorrow, ha? Balong ko lang si Doktor. Our topic will be antibiotics and probably 1 to 2 questions from your next topic. Kita mo quizzes, no? Because maybe you will be bombarded with the with reading the textbooks kung isaw nyo lang basahin ang yung textbooks for the exams. So, thank you. Kung may questions, question lang ha. A quiz tomorrow.